My name's Andrew Klein. I'm a consultant anaesthetist at the Royal Papworth Hospital in Cambridge. I'm talking today at the London Aortic Symposium in October 2018 about outcomes following major vascular and cardiac surgery. We have been reporting outcomes from vascular surgery in the public domain for the last 3 or 4 years, and it's available on a website for all to see, paid for by the NHS. And on that website you can see individual surgeons as well as individual centres that undertake vascular surgery in the United Kingdom and see their risk-adjusted mortality. So that is in the public domain and has been for a number of years. Well, headline findings are that in fact it's the patient that's the most important determinant of outcomes. The patient is the one with the disease, unfortunately, and their risk factors determine how they do after major vascular and cardiac surgery. In other words, older, sicker patients unfortunately have more complications and have a higher mortality after surgery. And that holds true wherever they're operated on and whoever the surgical and anaesthetic team is. So the patient is the most important determinant of their own outcome, and improving the health of our patients is the best way to improve their outcomes. There are a number of things that we can do to improve patients' health, such as getting them to stop smoking, to improve their physical fitness, to improve their diet, their nutrition, and to improve their anemia. So the main way, the most important way of improving outcomes is improving the patient's chronic health before surgery. There are a number of other determinants, and that is the centre that they're being operated on and the surgeon that they're being operated on by. And so our research is looking into whether centres have a significant difference to others and whether surgeons have a significant difference to others. Well, in cardiac surgery, we did a study on over 120,000 patients, and we found that in fact the patient accounted for more than 97% of the risk of their own outcome. 97%, really nearly all of it. The surgeon accounted for about 2 or 3% of the variability in outcomes. In other words, the surgeon had a small but important effect on the outcomes. And there were a number of surgeons who performed better than expected, but also a number of surgeons who performed worse than expected. So there was some variability in the outcomes of individual surgeons. There was no variability in the outcomes at different hospitals. So in other words, each hospital was as good as each other, and variability was determined by the actual surgeon themselves. There was also no variability depending on the individual anaesthetist. So in other words, anaesthetists all performed as well as each other, which is very important in terms of deciding whether to publish anaesthetic outcomes on the internet, like surgical outcomes. In other words, there is no variability. There's a high standard of care for anaesthesia. So therefore we concluded that it was important to continue to publish individual surgeons' outcomes in the public domain in cardiac surgery, and the government has continued to do this as a result and has decided not to publish individual anaesthetists' outcomes following our study. There is more variability in vascular centres than there is in cardiac centres. So there are more centres, and there are bigger ones and smaller ones. So we feel it's important to repeat our work in vascular surgery, and we'd like to see risk-adjusted outcomes by centre and by surgeons subjected to the same analysis to allow us to see if that conclusion is true. In other words, I can't give you an answer yet until we've actually looked at the data for vascular. There are some people who think there may be differences in outcomes between hospitals, which may lead to reconfiguration of services. So this is a very important question for patients. But it may also be that there is no difference, in which case we should keep the centres that are currently open. So it is an important study over the next 1 or 2 years to look at what variability there is between centres and hospitals in the United Kingdom.